The next talk is an update on transplant option for the treatment of aplastic anemia. Professor Borje Andersson from MD Anderson Cancer Center, please.
Again, my sincere gratitude for having been invited, and my thanks to Professor Tian and Dr. Parmar. Can you hear me now? Yep. Thank you. Okay, so it is a very exciting event for me to be allowed to come and present some thoughts around the transplant options for aplastic anemia as an alternative. Again, these are clinical thoughts. Dr. Parmar, Dr. Andrelini, Professor De Lima, and several others have been involved. Now, allogeneic stem cell transplantation is potentially curative as a treatment option for many patients with severe aplastic anemia. As Dr. Moti reviewed and showed, the overall response rate to immunosuppressive therapy in adults is around 60%. And that is very good. Unfortunately, it also leaves over a third of the patients failing therapy. And interesting. Treatment options, immunosuppressive therapy. I'm not going to talk about that. It was an excellent review just 5 minutes ago. Bone marrow transplantation as an alternative. Yes, depending on the age of the patient, I have provided this overview that my Dr. Pulsifer published a couple of years ago, which I think outlines how to go about the patients for those who have a sibling, who are young, who are in excellent shape, and who have a donor available. Transplant should be considered up front. If not, immunosuppressive therapy, and if response, maintain the immunosuppressive therapy. If not responding, however, then consider a stem cell transplant. And this was highlighted. This is an older study than Dr. Moti showed. However, reviewing this, it became apparent to Dr. Rosenfeld that it looked like this curve was composite and made up from really two subgroups. And when looking at this carefully, it became apparent that you had one subgroup that were the responders. They were doing excellent. And many years later, there were still over 80% of them who had responded early, who showed no sign of progression or recurrence of the problem that necessitated the immunosuppressive intervention. However, patients who did not respond in this subgroup, and the break point was set as a milestone at 3 months for evaluation of the immunosuppressive therapy, these patients do not do well, and these are the primary targets for the allogeneic transplant. Survival predictors after immunosuppressive therapy were identified as age. Younger age is better than older age. Unfortunately, we're not in charge of our age, and actually I can tell you from personal experience, it's not so bad getting old. It really beats the alternative. We can't do anything about it. Also for our patients, we have to deal with this as a fact. ATG and cyclosporin, short interval from diagnosis. We agree with Dr. Moti. Treatment should be started immediately to maximize the patient's chance to respond before complications accrue over time, and the risk of a serious complication is probably very similar each day. So if you delay therapeutic intervention, you also increase the risk over time that serious complications will arise. The severity of the condition In the EBMT database, this is no longer an indicator of a worse prognosis. Now, let's look at the refractory patients, those who did not respond to immunosuppressive therapy, since this is the scope of my talk. Do we or do we not have a suitably matched donor? If yes, go to transplant. If no, we have a problem. Repeat the first course of immunosuppressive therapy. A second course sometimes gives a response. And also consider unrelated donor or alternative donor transplant, which still today should be done under the auspices of clinical trials, preferably. Haploidentical transplants, at least in the United States, are not standard of care yet. Neither is a cord transplant for this type of disease, even though it is likely that it can be considered standard of care within the next few years in many places, depending on the outcome of ongoing trials. So, there are several issues with allogeneic transplantation for severe aplastic anemia. Toxicity of the preparative regimen, partly related to age. The median age of the patients that we deal with, and I'm an adult transplanter, is such that regimen toxicity has to be considered in the overall evaluation of the patient. Engraftment can be a problem depending on how long the immunosuppressive therapy has been ongoing and the number of transfusions the patients have been through. At MD Anderson, the typical patient that we see has had well over 20 transfusions before they even get referred for evaluation for a transplant, and I'm sure that other centers have similar scenarios. Graft versus host disease is a potential problem that impacts quality of life and long-term outcome. Cell source, the graft, should we use marrow or should we use peripheral blood cells? And finally, alternative donors. So, donor type and recipient age. Let's look at that. Donor type, HLA identical sibling donors. Patients do better than for those who have had an unrelated donor. These patients have been treated over the last 10 years. It was reviewed by Dr. Saucier from Hôpital Saint-Louis in Paris at the most recent ASH meeting, and these are data from the EBMT, clearly showing that at 5 years post-transplant, there is about a 10% difference between patients who have received an allotransplant from a matched related donor versus those who get an unrelated donor graft. And this is also depicted in this slide that I borrowed from the IBMTR, where in young patients who have a sibling donor, on average, at 5 years, we have close to 90% survival. And with older patients with a sibling donor, more than 20 years old patients, it goes down to about 70% at 5 years. And with unrelated donors, these survival estimates drop by about another 10%. And the same has been reported previously as well from Europe. It's most notable and worrisome that the D group, patients who are in the older age bracket, like Dr. Moti and myself, above age 40, where we expect that only about 50% of the patients will be doing well alive more than 5 years out from transplant. Whereas the youngest patients, those below the children, they are well matching the data from the United States with about 90% survival at 5 years. So, regimen type. How do we prepare our patients? Cyclophosphamide versus cyclophosphamide fludarabine versus cyclophosphamide with ATG versus fludarabine cyclophosphamide with ATG. If so, what type of ATG? Most commonly in the transplant setting in the last several years, rabbit ATG have been used, and the jury is still out as to whether horse ATG would be matching better or worse, as was just discussed. However, CAMPATH has also been discussed in this setting. If we start with whether to use ATG or not, Dr. Champlin and Pasveg reviewed this in a large study published 5 years ago, where patients who were conditioned with cyclophosphamide and ATG did considerably better over time than those who received cyclophosphamide alone for conditioning. And a subsequent paper that was recently published showed that with the addition of fludarabine, the problem of graft failure decreased such that patients conditioned with fludarabine and cyclophosphamide plus minus ATG do considerably better than those receiving cyclophosphamide alone. And these are patients who are adults. Recently there also came a review from the United Kingdom where a large trial had been completed that was carried out across the country, multi-center trial, comparing cyclophosphamide versus cyclophosphamide fludarabine and addition of ATG versus CAMPATH, matched related and matched unrelated donors. And briefly, adult versus children. Oops, this has really a life of its own. I'm not sure what's going on here. How interesting. So the brief summary of these data is that patients conditioned with fludarabine cyclophosphamide do better than those with cyclophosphamide alone. Secondly, matched unrelated donors, higher risk for complications than using matched related donors, and patients who were conditioned inclusive of alemtuzumab or CAMPATH did better than those patients who had been conditioned with ATG as part of the regimen. The caveat here when looking closely at the report is that the ATG dose used is about 3 times higher than is commonly considered ideal for support of engraftment and prevention of graft versus host disease. The total dose that is now being recommended by most groups using rabbit ATG as part of a pre-transplant conditioning regimen is in the order of 4 to 6 milligrams per kilo total dose for a typical peripheral blood or bone marrow transplant. And the dose that was used by the Brits is about total dose of about 15 milligrams per kilo, which has been correlated with an excessive amount of post-transplant infections and protracted immune suppression, as well as post-transplant lymphoproliferative disorders. So personally, I would question to some extent as to whether there is a true superiority of alemtuzumab or whether this has been partly related to an excessively aggressive use of rabbit ATG, which caused an unnecessary amount of complications and side effects. The exception in the subgroup here was the pediatric patients who did the group C here, where the patients did as well regardless of if alemtuzumab or ATG was included in the conditioning regimen. So, if we summarize what has been published in the last several years, overall survival at 3 to 5 years with matched related and unrelated donors is in the order of 65 to 85 or even 90%. There are a few small series that have even higher survival rates. More also striking is that most series that rely on including ATG and alemtuzumab have about a 5 to 10% engraftment failure, and the patients will need to be addressed so they don't die of secondary aplasia after the transplant. That was not successful. Stem cell source, marrow versus peripheral blood. At least two large series have addressed this retrospectively, primarily from the CIBMTR side. In patients who are young, less than 20, or children, bone marrow turned out to be retrospectively superior to the use of peripheral blood cells. And in patients who are older than 20 years, the picture is the same. Overall survival is better for patients receiving bone marrow rather than peripheral blood, likely because of an increased incidence of graft versus host disease and associated complications. And this was recently updated by Mary Epen in Blood, showing that grade 2 to 4 acute graft versus host disease was significantly higher for patients receiving a peripheral blood cell transplant, and overall survival therefore decreased as well with the use of peripheral blood cells as compared with bone marrow. And when there is no need for a rapid immune reconstitution to obtain a massive graft versus tumor effect, bone marrow is to be preferred. Finally, newer regimens are being discussed. Cyclophosphamide fludarabine is a good regimen. It provides engraftment, especially in children, quite easily and with fully matched donors and when a full dose graft such as bone marrow can be used. However, when there is an increasing disparity between the patient and the graft, such as the situation with cord blood transplants and where you have few cells as well, and with haploidentical transplants where you have a larger number of cells in the graft, but still a fairly significant difference in tissue makeup, there needs to be more intense immunosuppression. Small number of patients have received cord blood transplants and haploidentical transplants so far and have been reported. This approach has been reported successful, primarily in children, and there have been few transplants reported so far in adults. But trials are ongoing, and the data that are available look very promising. One paper that was recently reported in Blood showed the conditioning of using fludarabine and low-dose melphalan together with low-dose total body radiation, and as you can see with cords, in a handful of patients they reported a survival of about 80%. So this looks, for a pilot study, very promising at this time. So in summary, we have major predictors of outcome: patient age and the interval from diagnosis to transplant carries a message. Shorter interval is better, as can be expected, because the longer interval carries with it the risk for infections and also the likelihood of increasing number of transfusions with alloimmunization and iron overload. Bone marrow is the preferred stem cell source. Standard conditioning regimen: fludarabine, cyclophosphamide, ATG, probably at this time, possibly with Campath as a hot contender, at least in Europe, where it has been used for many years now, several decades. Fludarabine, cyclophosphamide, and ATG in MUDs, and match-related donors also in patients above age 30. Finally, the question that I have is if it is possible to justify including TBI still for any patient subgroups. because the data that have been produced in most series look as good with chemotherapy alone versus those that include even low-dose TBI. There are many unanswered questions. For unrelated donor transplants, when should they be done? Or should there be alternative donor transplants? What should be the conditioning regimen? Have results improved enough to justify earlier interventions with transplant, or should one rely more on immunosuppressive therapy? And there is a lack of long-term quality of life data post-transplantation still today. At the biological level, telomere dysfunction has been shown to be part of the mechanism involved in the pathogenesis for patients with severe aplastic anemia. Does that have any impact on the outcome after transplant and on engraftment? Nothing is known that I'm aware of, at least. And what are the biological markers to predict a favorable response versus non-engraftment? Cytokine profiles, telomere length, and finally, we would benefit from establishing a separate severe aplastic anemia registry to respond to some of these questions, or give the task to the subgroups of the registries that are already in place. And gosh, it gets complicated here. But I promise I will stop now. So if you have any questions, I will be happy to address them together with the other speakers. Thank you very much for your attention.